Thank you very much. Good morning and belated welcome, and I'll hand it over to David. Thank you, David.
Thank you, EJ. I want to thank the Empire Center for putting today's event together. You know, we live in such polarized times, and especially when I look at Washington, you can't even talk to the other side. You can't even talk to people that you disagree with. And New York's a lot better than that. So thanks to the Empire Center for creating that kind of space where we can have a very robust and balanced, just serious discussion about policy issues. Policy is key. When we did the prep call for this, I asked the panelists, like, you know, let's not get too hung up on the politics side. We'll focus more on policy, although, of course, you can't totally disentangle those things. Had Bill been here on time, he would have given you the brief lay of the land, quick single payer, New York Health Act 101. But I've looked around the room, it's a very expert crowd, so I'm going to dispense with that because I think you know the basics and jump into our panel discussion. I'll also dispense with the formal bios. You have those in your packets. But we have a very distinguished panel, of course. We have Assembly Member Dick Gottfried, the very long time sponsor of the New York Health Act, 20-some years now. I was teasing him over coffee. Maybe he's a man ahead of his time between gay marriage and marijuana and single payer. You know, he's at least in the thick of all of the debates. It just took a while to get there. We're also joined by Senator Gustavo Rivera, the newly named chair of the Senate Health Committee. Congratulations to you on that, Senator. And also B. Grause, the president of the Healthcare Association of New York State, and Sean Doolan, general counsel to the New York State Conference of Blues. And you know all of them, they're very knowledgeable people. So in the order I introduced them, I asked them each to give a very brief opening statement, emphasis on brief, just to get the ball rolling. I'll ask the panel some questions then, and we're going to try to save about 15 to 20 minutes for the audience and your questions too. And you know, my only request to the audience is please do ask questions, not statements, not speeches, really questions, and try to be brief so we can get as many people involved as we can in the time that we have. So with that, Assemblymember Gottfried.
Well, good morning. Since Bill Hammond is not here yet to give you a summary of the bill, I'm not going to do that, but if you read the summary of the bill in Bill's report, it's a terrific explanation of what the bill does. After that, it kind of goes off the rails, but the description of the bill is really terrific. You know, millions of New Yorkers can't get health care they need or face financial hardships and obstacles to get it. That's not acceptable. I don't know anybody who says it is acceptable, but there is no way to meet that need other than the New York Health Act. We're talking about real families. You know, about a year ago, the Federal Reserve Board reported that 40% of American households could not come up with $400 from their savings to meet an emergency expense. A few days ago, another report said that 60% of American households could not come up with $1,000 to meet an emergency expense. Now in New York, that's 12 million people, 60%. And that's in a world in which the average deductible on insurance policies is $2,700. So what does a family do that can't come up with $1,000 when they've got an insurance policy with a $2,700 deductible? And the answer is that in a typical year, in any given year, a third of households who have health insurance, report that at least one member of the household went without health care because they couldn't afford it that year, and in most cases it was for what they regarded as a serious condition. And this burden is not at all distributed based on ability to pay. The insurance company wants the same premium and wants to impose the same deductible, whether you are a multi-million-dollar CEO or the receptionist or the janitor. And the burden is even worse if you're a working family that has a serious illness or has somebody who needs long-term services and support, which can just totally wipe out a lifetime of savings. Wealthy people, on the other hand, tend not to face those problems. I don't know if there's anyone in this room today who's part of the group that couldn't come up with $400 for an emergency expense or $1,000 for an emergency expense. I'm inclined to doubt that there are many people in this room who are in that part in that huge part of our population. And at the same time, we are burning tens of billions of dollars a year in New York that should be going to pay for health care or back into people's pockets. Under the New York Health Act, we would save about $20 billion a year that we are now spending on insurance company administrative costs and profit. We would save about $16 billion that healthcare providers now spend on administrative costs to fight with insurance companies. They spend a lot of other money on administrative costs, but that's just the portion they spend fighting with insurance companies. We would save about $18 billion from the fact that we would be negotiating with drug companies on behalf of 20 million covered lives, driving down prices, for a total savings of $55 billion a year in money that is now going to make nobody healthier. On the there would be additional spending. We would be increasing spending on healthcare by about $26 billion. We would be spending about $18 billion on long-term services and supports that is now being provided. The euphemism is unpaid, meaning a family member, usually female, is giving up her career and a large part of her life to take care of a relative. Savings of increased spending of $44 billion a year for net savings of $11 billion. We would be replacing current spending of $131 billion on premiums, out-of-pocket costs about $29 billion, the local share of Medicaid about $9 billion. So we would be replacing a total of $169 billion, minus the savings of $11 billion. So we have to raise $158 billion, and that would be raised by the progressively graduated New York Health Act taxes. So the key elements that I see are, number one, we would stop wasting tens of billions of dollars a year and start putting that money either back into people's pockets or into healthcare. The fact that we would all be in the same boat, to me, is important, not as a matter of social equity, which is important, but because it is what guarantees the quality of the program. When you have a program where every voter benefits and every voter has a stake in the quality of that program, that's what assures that a publicly accountable health program will be as good as it can be. There would, for the first time throughout our healthcare system, be a balancing of pressures. Today, almost all the pressure is downward. In the Medicaid program, any program for poor people in this country, the pressure is downward. Even in the Medicare program, the downward pressure is not quite as strong because people like older adults better than they like poor people. But certainly in the insurance world, the pressure is overwhelmingly downward because with group coverage, insurers know that their customer is not the patient, their customer is the employer who has a legal obligation, as does the insurance company, to return every possible dollar to its stockholders. And even in the individual market, the pressure is overwhelmingly downward because when you go to buy health insurance, you face a blizzard of information And invariably, people look at one piece of information, the premium. And so they end up buying a plan that has kept its premium down by having an extremely restricted provider network, very little, if any, out-of-network benefit, and an enormous deductible. So again, even in the individual market, the pressure is all downward. And finally, the other core element of the concept is that we would be paying for all of this fairly. The way I think basic social needs ought to be paid. You know, the dollar that puts bread on the table should be taxed at a lower rate than the dollar that puts caviar on toast. I'm told that's what you do with caviar. To go back to the beginning, millions of New Yorkers are going without health care or are facing enormous financial obstacles and hardships to get it. I don't think that's acceptable. I doubt anyone in this room thinks that's acceptable. You're going to hear some suggestions later this morning about ways to tinker with the system. None of them is going to affect the profound problems with the current system that I've talked about, other than the New York Health Act. Thank you.
Thank you, Dick. Bea, would you like to go next?
Yes, thanks, David, and thanks to all of you for braving the cold and making it here. I guess I'd like to start out by saying I approach this conversation from experience. I spent 14 years in Vermont and as the head of the Vermont Association of Hospitals and Health Systems, and worked with policymakers and administrators for 4 years as the legislature there passed their version of the New York Health Act and worked through it before Governor Shumlin decided to pull the plug on it. So I also come at this as a registered nurse. I worked as a registered nurse for the first 10 years of my career, and think that the conversation around whether it's the New York Health Act or Green Mountain Care or Medicare for All at a national level, the conversation should begin and end with patients and how we are going to meet the needs of the population we're trying to serve. And in New York, we have 19 million patients in that light. We are one of the oldest states in the nation. We have, I'm blanking on it right now, millions of senior citizens and others, knowing that your per capita spending for seniors is about 3 times those of adults under the age of 65. Demand is a major driver of healthcare spending. As I'm sure we'll talk about today, there are many reasons for increased health spending growth, but again, it begins with patients and how we have built a system over decades and how we treat those patients. 20% of our economy almost is devoted to healthcare. As I like to think about it, it's a big battleship to turn. No matter what you do, whether it's evolutionary or revolutionary. And the other major demand on a factor to consider is workforce. As I like to say, we want to make sure that patients get the right care at the right time in the right setting, and that very much has to do with whether or not we have the right healthcare worker to care for them. Fundamentally, even though healthcare at the hospital level is very capital intensive, it is primarily people taking care of people. And that's a very important factor to think about as we think about the workforce needs of our aging population. While I agree with the issue of affordability, as Chairman Gottfried raised, we have 57% of New Yorkers are at 400% of the federal poverty level or less. So who pays is a big question, and certainly a big policy question. New York actually has made tremendous strides in improving our healthcare system. We have 1.1 million, by our numbers, of New Yorkers who lack healthcare coverage currently. That's really, we rank, and again, maybe it's the top of a bad heap, but we rank very high compared to other states in terms of our ability to provide coverage. 95% of New Yorkers have access to healthcare coverage and do have coverage. We also have reduced per capita spending. and have made tremendous strides in improving, again, speaking from the hospital level, improving quality and reducing harm and improving quality and patient safety. Bottom line is that we have a hybrid system. Certainly Medicare and Medicaid are major payers in our healthcare system, but every single payer system in every other country around the world is also a hybrid system. So it is a balance of private and public, and certainly one of the most important things is what is the role of state government if you're in a publicly financed healthcare system. My recommendations and my hope for this conversation, and I do believe it's a very important conversation to have, is that we do need to identify and really understand the problems that we're trying to solve. I think that in my view, all of the issues, and if we were to create goals, I would love to have Republicans and Democrats support over the long-term goals that would focus on improving the health of the individual and the health of the population. That would be the first goal. The second one would be, how do we improve value? Again, it's a big battleship to turn. How do we improve quality and patient safety and decrease costs over time? And what are the goals that we set in order to do that? And finally, again, as we think about all the questions that I'm sure we're going to raise today and beyond, how do we, even without public financing, what is the role of state government in healthcare, and how do we help to work together in the private sector and the public sector to improve health? We have a very good system that's good at intervention, and we're still learning and beginning to learn about how do we create a public system and a private system that is much better at prevention. So with that, I will stop.
Thank you, Sean.
Thank you, David. Yeah. I would agree with Dick Gottfried. Pause. on one critical. I think each of the people on this panel and in the room share the common goal of providing access to high quality and affordable health care for all New Yorkers. In fact, universal health care is not only aspirational, but for the first time in history is within reach. Obviously, where we part ways is how to get there. A single payer or a government-run health plan is but one pathway to universality. Another path is through, as B mentioned, the public-private partnership, which is foundationally in place here in New York. Whether you are a supporter or were an opponent of the Affordable Care Act, no one can dispute its success in reducing New York's uninsured rate from 12% to historic lows of just over 5% statewide, 4% upstate. Whether it be expanding Medicaid, adoption of the essential plan, or building the infrastructure for a state-based exchange, the governor and the legislature deserve enormous credit for taking full advantage of all that the ACA had to offer. A more granular review of New York's uninsured number is even more impressive. Of the roughly 1.1 million people uninsured today, about 330,000 are otherwise eligible for Medicaid. They can get coverage immediately, effective immediately, at no cost. Likewise, there are about 520,000 people who are between 138% of the federal poverty level and 400% of the federal poverty level, and are potentially eligible for low-cost or subsidized coverage. Focusing on enrolling these individuals into available low or no-cost coverage would drive the uninsured rate in many counties of the state, especially upstate counties, to nearly zero. The ACA has also established a baseline of comprehensive health benefits and laid the foundation for bending the curve in reducing the cost of coverage. For example, in the first year alone, the cost of individual coverage in New York was reduced by 50%. Moreover, in a recent national study of the cost of private health coverage among the 306 most populated cities in the country, Rochester was found to have the third lowest cost, Buffalo the fourth, Syracuse the 15th, and here in Albany the 29th. No industry is more heavily regulated than the health insurance industry in New York, and no state regulates health insurance as stringently as New York does. whether it be restrictions on margins in the insured market, limitations on administrative expenses, uniform policies and procedures, or standards for marketplace conduct. New York mandates rules of the road which in many respects require the commercial market to compete purely on affordability and the quality of services provided. In that regard, one might argue that New York has the unique quality of a heavily regulated yet highly competitive marketplace. While health plans can and should do better, much has been accomplished in New York, both with regard to affordability and reducing the ranks of the uninsured. The question here becomes, is this market worth preserving? In contrast, single payer would replace the current system with a government-run plan that begs the question, to what end? The Rand Corporation, which is really the only objective assessment, independent and objective assessment of the legislation in New York, estimates that single payer would produce savings of 1%, rising to 3% by the end of year 10. These savings are based on reduced administrative cost, reduced payments to providers, and reductions in the cost of prescription drugs. In reviewing our own Blue Cross and Blue Shield plans reimbursement and claims data, the potential savings, as modest as they are projected by Rand, are dubious at best. For example, the provider savings are based on reducing the cross-subsidy of commercial insurance that exists today to Medicare and Medicaid. Our own data, however, reflects a far greater cost subsidy of commercial coverage exists today than projected by Rand, which will either necessitate a far greater cut to provider reimbursement or a greater cost to the system. Likewise, the projected administrative savings are based on reducing administrative expenses of commercial plans to be comparable to Medicaid. Commercial plans, Rand projects at 18% administrative expenses. Medicaid, they project at 6%. For a variety of reasons, this is a specious comparison in that the administrative functions are far greater in the commercial market today, greater obligations, than in Medicaid, which is purely a claims payment function. Finally, the prescription drug savings are projected to be 10% off of the current Medicare rate, based on the Rand analysis. The premise for such savings is based on the economies of scale generated by one entity bargaining on behalf of the state. Unfortunately, the state's own experience in scale bargaining, the state's Medicaid program, has not produced anywhere near comparable savings. These are just a few of the more questionable assumptions. In Rand's own defense, they acknowledged that they were relying on highly uncertain assumptions. Without the projected savings, either provider reimbursement will need to be cut further, taxes will need to be increased more, or healthcare utilization will be stifled. Without these changes, the model becomes unsustainable. With such a dramatic change to the healthcare delivery and financing system contemplated by single payer, not to mention the legal issues of capturing the 40% of the market that exists today that is self-insured and protected by ERISA, or the negative ramifications of the largest state tax increase in history, the upside of single payer, in our judgment, needs to be more compelling. In our minds, needless to say, we think there's a better way. Thank you, Dave.
Thanks, Sean. Senator.
So I agree with Sean, but only in one thing. I agree with Dick, I agree with you. I agree with you that, and I think all of us in this room certainly want for universal coverage to exist. Right? I think that, and certainly there were things that we can do, even this year, to make sure that we move in that direction. The question that we have to ask ourselves is, if we do expand the coverage to everybody, are we still leaving the things that the system currently has that are problematic in place? And that is the reason why the New York Health Act is necessary. Yes, we want to make sure that we cover everybody. If we want to make sure that the folks who are currently undocumented, or those folks who are or just who don't have coverage, who are eligible for coverage but don't know it, can get access to coverage, can get connected to what they're eligible for. But once we do that, we are still left with a system that has all sorts of problems in it. There are countless stories of individuals who, while insured, are consistently making decisions about their health care that have nothing to do with their health care. and have to do with their finances. There is, for example, a young man, 30 some odd, 35 years old, married, works in a finance industry, has great health insurance, but has a deductible which he has to spend out of pocket before he actually gets coverage. So he has to make decisions about, and this is actually a real person, I'm not identifying him because he didn't want to be identified, but there's a lot of stories, for example, that we've been able to get from people who do want to be identified, who talk about the conditions that they, for example, a 30-some-odd-year-old woman found a job that she'd been looking for a long time, has great healthcare coverage, doesn't kick in until 30 days, where she's employed. Something starts to show up in her skin that tells her that she might have a condition that she had when she was a child is kind of coming back, a rare blood disease, and she has these lesions in her skin, and she has to make a decision about whether she goes get it looked at or whether she waits for the 30 days. Waits for the 30 days, goes get it looked at. Indeed, the condition had come back. It got treated, but in those 30 days, God knows what would have happened. Or other conditions in which there's another gentleman, 55, retired, had to have a double hernia surgery. And then it was decided by the insurance company after the actual operation had happened that that person was eligible for Medicare under their particular condition, and so they took the payment back, and that person was now in debt. So the question here is, yes, we do want universal coverage, and we want to move closer to that. And again, even before we pass the New York Health Act, we can and should move towards universal coverage. But if we leave the system as is, where decisions are a lot of times made either by insurance companies or by individuals that have to do more with their finances and their health care, that is a problem, and we have to fix it. So I'm going to keep it brief so that we can get to questions, but that's the reason why we believe that we need to do this. And look, we know that this is a complicated thing, and we know that conversations like this are incredibly important to have so that we can get to a bill that we can all agree on. But the reality, as we've talked about before, even though a lot of individuals, maybe in this room, agree that the system is broken, the option of the status quo seems to be the only thing that they are offering. So we want to move forward with a different vision that, yes, it's a vision that might be a little bit scary to some, but for many of us, this is a moral question. We have to move towards a system in which, regardless of what your wealth is, you should have guaranteed access to health care. I believe that. I believe that health care is a human right, and that we need to move in that direction. I believe it is possible, and working together, I think we can get there.
Thank you. So let's play that out a little bit more before we get into more detailed questions. There's only 4 people on this panel, but you have like fundamentally different worldviews sitting to my left, right? There are people who think the system is so fundamentally broken, completely beyond repair, and they make a good argument, right? There's a lot of people who are still left out. Affordability is a huge issue. We have a lot of inefficiencies, and we have lots of providers who are on very shaky ground. You know, you could make a good argument. There's an equally good argument that there's lots and lots of good things we wouldn't want to give up, right? New York proudly has an incredible public insurance safety net in the form of Medicaid and CHIP. New York made enormously good advantage of the ACA, with the lowest uninsured rate in our state's history. And you can go, and most people like their coverage. If you look at poll after poll, that's what most New Yorkers and most Americans say. And it's a potent political promise to say, if you like your coverage, you can keep it, and you know, you might break that promise at your own peril. So, how could we ever reconcile these 2 fundamentally different worldviews, irrespective of any details in a plan?
I don't know that you can. I mean, if that's a question, I don't know if you can reconcile it. You know, one of the reasons why most people say they're happy with their coverage, and I'm, you know, I think if you ask the question a little differently, you'd get very different answers. In a given year, most people don't have major medical expenses. You know, it's like you can be very happy with your auto coverage until you have an accident. Then you discover what a terrible policy you bought. If you're not bumping into your deductible and you're not being told, no, you can't go to the doctor, that your primary care doctor thinks ought to treat you, if you're not bumping into that, what's not to like? But when you do need to use your coverage, then you discover what's wrong with it. People who say, yes, I agree with you, we've got all these problems, but there must be a better way than the New York Health Act. Tell me. I haven't heard one yet. Is there another way to shrink the 18% of the premium dollar that insurance companies spend on administrative and executive salaries and profit, and to shrink that down to the 2% administrative costs of a single-payer system, other than by moving to a single-payer system? Is there a way to get rid of the restricted provider networks and deductibles and copays that you now have in the system? We can't tell self-insured plans to get rid of all those features, because we can't tell self-insured plans who cover more than half of our employment-based coverage, we can't tell them to do anything. And if we do tell insurance companies to only spend 2% on waste and administration, and we do tell them to not have deductibles and do not have restricted provider networks and do not have premiums that hit working people harder than wealthy people, when you get finished doing all of that, what's the point of having insurance companies? Other than to enable a handful of private companies to somehow make a lot of money. But if we're restricting how much money they can make, even that point has gone away. There are countries that administer a universal coverage system through extremely tightly regulated private insurance companies. And people say, well, why don't you do like Switzerland does? Well, my answer is, why? What's the advantage of making doctors deal with a half a dozen different payers than with one? They can't compete on the services they provide, because in a universal system, we're telling them all to provide the same thing. What advantage do you get from breaking it up into a half a dozen different companies? And by the way, I haven't heard anybody propose that we run the system through a handful of companies that are limited to 2% on the dollar and no deductibles and no copays, et cetera, et cetera. That would be an interesting discussion. So far, nobody's offered it. So people who say, oh, there must be a better way, I'd sure like to hear it. I've had my ears open on this topic for over the 27 years that I've been sponsoring this bill. I haven't heard anybody come up with a mechanism that solves the problems that are a burden on the lives of millions and millions of New Yorkers, other than the New York Health Act.
I guess I would like to counter that, Chairman Gottfried, in that I think the way to start to unpack the problem is to really focus on the facts. And I think that there's a lot to learn. As I said before, healthcare is almost 20% of the economy. And I think there are many facts about our healthcare system that are important to understand. And I think that you mentioned the first one, one of them, which is that almost half of commercial coverage is covered under ERISA and therefore not touched by the New York Health Act.
ERISA plans would largely disappear. We can't outlaw them, but who would bother to have one under the New York Health Act? But there's nothing else you can do as a state to touch ERISA plans. You can create a system in which an employer would be a lunatic to spend the stockholders' money on a self-insured plan. And so self-insured plans would disappear under the New York Health Act. We're not allowed to outlaw them, nor would we have to.
I'm not sure that would happen. I think there are many national companies that would choose to continue their ERISA coverage. But my point being is that that's not a guarantee, and it certainly wouldn't happen overnight, even if they did choose to join the New York Health Act or have their employees get health insurance under the New York Health Act. And so for providers, it wouldn't be single payer, it would be fewer payer. And so your administrative savings would not happen overnight. And the experience in Vermont was that it was definitely on the provider side. It was more, as one of my former hospital CEOs said, it was more pick and shovel work to try to figure out how to achieve administrative savings over time, at least on the provider side. And again, I think while we all support the goal of coverage, again, the importance of really understanding what is happening in our healthcare system. I disagree that our healthcare system is a disaster. It is not a disaster. There are, we have, at least on the hospital side, all hospitals are not-for-profit. They're open 24/7 if people need care. When you think about, while people are, as you said, most New Yorkers do not use medical services, millions and millions of people use medical services every single day. And many of them have very complex medical challenges that they are dealing with on a daily basis. Can we do a better job? Absolutely. But we're making, with technology and innovation, which is another point I wanted to at least inject here, as it's important to continue to have the ability to innovate and continue to improve the delivery of medical services over time. For example, total hips used to be, when I worked as a nurse, used to be in the hospital for 10 days. It's now done on an outpatient basis. Total knees, same thing. Cataract surgery is now done on an outpatient basis. We're moving a lot of services through the advent of medical advances and technology to the outpatient setting, and we're just beginning to figure out how factors such as nutrition, violence, and other community factors impact medical spending, and we're just beginning as a state to learn how to address those, and I think that's an area of focus.
I haven't criticized our doctors in hospitals. What I've criticized is how we pay them.
Okay, so let's move to another big picture question. Growing support at the national level for whatever you want to call it, single payer, Medicare for all, other phrases, they're all used with great imprecision. But even if they don't know what they mean, they like it. And there's growing support across the country. It's a litmus test for some Democratic presidential contenders. For even those who think single payer in some form is the way to go, there's also a mega debate, should this be done at the national level versus a go-it-alone state approach? And I invite anybody, and B, maybe you want to share a little bit more of your Vermont experience on that, but I'll hold you for last. Okay? And Sean, because I thought you were shaking your head and Senator too.
Sure. Certainly at the federal level, adopting, whether it's Medicare for all or single payer, would eliminate some of the economic disparities that might result for adoption of a single payer system in any one state, whether it be New York or otherwise, in the sense that you've got a broad-based tax and you won't be forcing businesses out of the state. But I do want to come back to a couple of facts in terms of the profit margin and the savings. In New York, under the Department of Financial Services review process, the margins for individual coverage, people who purchase their coverage today, are only approved at 1.5%. Small group at 2%. That's the cap. In many respects, New York is imposing, a non-for-profit culture in the for-profit to the extent that it exists in the downstate marketplace. Simply, that all being said, affordability is definitely a challenge across all spaces, whether it's employer-based coverage or individual coverage. Simply replacing the payer source, however, doesn't get at what is driving the cost of coverage. Certainly there are savings that can be further incurred in the commercial space on the third-party payer system, but you have unsustainable increases in costs, and there's precedent. You look at those countries that have enacted single payer, the United Kingdom and Canada, what has been the result? Obviously, they experienced the same unsustainable growth in cost, even though they had a single payer. What ultimately resulted? Challenges with respect to utilization, health rationing, lines to receive coverage, people moving from Canada to seek coverage to the United States. So it's affordability is a major challenge, but it's not simply the payer, but replacing the payer source doesn't solve that problem.
Senator, national or state?
But certainly we want for this to be a national, the national solution would be the best solution. There's no question about that. But we don't have to talk too much about the orange madness in DC to talk about the fact that this is not something that's even under consideration there. And I do believe
Your colleague immediately to your left, he knows how to play the long game on this issue.
certainly, as I remind my staff, he has been in the assembly for longer than I have been on this earth, and he has been the chair of the health committee for longer than most of my staff have been on this earth. So I certainly, I certainly recognize there's a lot of knowledge there. But just to answer your question, I certainly believe that a national solution would be a better solution. But that is unlikely to happen at any time soon. Now, if we do get not only a friendly administration, but a friendly Senate and House, and we can kind of move in that direction. And as you said, there are political conversations that are happening nationally that right now with the potential candidates for 2020 and the Democratic side that are talking about that as part of their platform, then certainly we can move in that direction. The goal here to our state should be, we need to care about New Yorkers. We care about New Yorkers, and we believe that the current system, which I would, by the way, to agree with a lot of what he was saying regarding, we have, in the state of New York, or in the case, in the US, there is a fact that we have the best healthcare system in the world, if we can afford it. If you're wealthy, you would have no problem getting access to care. You would have no problem getting access to care to the best doctors at the time that you want to be cared for, that to get looked at by the specialist that you would want to be looked at by, et cetera, et cetera. That's not the reality for most folks, including those individuals that are insured. So it would be, certainly having a national solution would be preferable, but since that is unlikely to happen anytime soon, we want to push for a state solution to it.
And B, I mean, you already brought up Vermont, and you know, they took a much harder look than many states thus far. Much smaller state than New York, of
Sure.
course. There's 2 or 3 payers, I think, in Vermont. So, you know, not easily comparable, but might you share a little bit about what you think is relevant?
I could share a lot, but I won't. Yes, Vermont passed Green Mountain Care, so the law passed, the governor supported it, and they spent 3.5 years trying to figure out how to implement a single-payer system. They did a number of studies on what physicians would do, where were people getting care. We eventually learned that 1 in 5 Vermonters didn't actually even get their care in Vermont. They got it in New Hampshire or New York, and many other aspects. What would happen to the workforce, and ultimately it was who pays. What would happen to Vermont's tax base, that was mentioned in the RAND study as well, that became the reason why they didn't wind up implementing it. But we learned a lot along the way. Green Mountain Care was passed in 2011. The Affordable Care Act was passed in 2010. Vermont was one of the first states to receive a state innovation model grant, which New York has, $45 million. And the focus of that grant was really on a very important question, not whether or not Vermont should publicly finance healthcare, but what would they publicly be financing, and was the system, the delivery system, set up to actually produce health in a more efficient and improved way. And that is work actually that Vermont is continuing today. So that's again part of why I think I walked away from that experience really believing that the devil is in the details, and what we are doing as part of the private sector versus the public sector. What are we doing to actually improve health in ways that are continuing to get better over time, so that we're improving value? I think we can all share that desire to actually improve that value proposition for both taxpayers and ratepayers, and it's work that's not easy, cheap, or quick.
Assembly
if I
member,
could-
let me ask you, it's actually a follow-on on this national state issue, if I can. in laying out your case for New York Health Act, one of the advantages you cited was everybody needs to be in the same boat. Everybody has a stake in the same system, making it high quality, making it work, right? I think that's what you said. So could this still work, even if we didn't get that federal waiver and have Medicaid and Medicare folded in? Does this possibly still work in your eyes, or is that, absolutely essential?
Well, first of all, folding Medicaid, Medicare, and the Affordable Care Act in do not require waivers. It can be more easily and with less complexity done with federal waivers, but the program works, including folding in Medicaid, Medicare, and the Affordable Care Act, even if the federal government does not cooperate at all. So waivers, terrific to have. They'd make it simpler, but not necessary. The polishing and improving the delivery system are important things, and we all work on that. But that's not what this discussion is focused on. What this discussion today is focused on is whether millions and millions of New Yorkers, not just the 5% who are uninsured, but whether the millions of New Yorkers who are insured get access to that improved system. In Canada, the Canadians have chosen, in their wisdom, to spend half as much on health care as we do. They are actually very happy with that system. Nobody in New York that I know of, certainly not me, is proposing that we cut our health care spending in half. I'm proposing that we cut a lot of the waste in administrative costs and the excessive prices we pay to drug companies by moving to single payer, precisely so we can move the bulk of those savings into paying for health care for people, instead of having people paying for it out of pocket. No one's suggesting we spend half of what we now spend on health care as Canada does. And by the way, one of the reasons why Canadians sometimes come to New York or to other states for surgery is the same reason people in Vermont go to New Hampshire or New York for surgery. Not because they don't have good health coverage in Vermont, but because they have a very sparse population. The Canadian population is tiny compared to the US population, spread out over a vast territory. And so it's no surprise that often they come south of their border to find a place to get heart surgery. If you lived in Plattsburgh, you would have to travel like a Canadian to get heart surgery. Because Plattsburgh is a little town, probably a lovely little town, but a little town.
They go to Burlington.
All right.
Go there in the springtime.
Yes. And, Sean, the notion that insurance companies spend all but 1.5 or 2% on health benefits in the individual market, I've never heard anyone suggest anything wildly close to that number.
That's margin.
Margin.
You mean their profit margin? Okay. But, so we're still wasting 15, 18, 20 cents of the insurance dollar on administrative costs. Maybe the shareholders aren't getting it. Maybe the multi-million-dollar CEOs and an army of clerical workers whose job is to run you around as much as possible until you give up.
Executive compensation is less than 1/10 of 100%. So I mean, it's around the margins.
But we're still talking about spending 18 cents on the premium dollar, as opposed to the roughly 2 cents on the premium dollar that a public single-payer system spends on administrative costs. That's billions and billions of dollars. And in Canada, doctors and hospitals spend radically less money on administrative staff to fight with their payer than doctors and hospitals spend on administrative costs to fight with our payers. And that's all money that ought to be going either back into the pockets of workers and employers or into paying for health care. And there's no way to get there other than a single-payer system.
So, Sandman, you've kind of opened the door to another big question. You know, if you read the Rand report, you quickly realize this is not just a healthcare policy, this is an economic policy. You know, their modeling does suggest, you know, a lot of income and wealth redistribution under the New York Health Act, right? With a majority of low-income, middle-income households doing better in some way, right? Overall, they would pay less for healthcare than they do now, and wealthier New Yorkers paying a lot more in some cases than they do now. Some people would say, that sounds great, economic justice at work. Other people would say this will absolutely destroy the New York State economy. So I'd welcome all of you, if you'd like to jump in on that. Just tiny little question.
Well, you know, over the years, we've raised our taxes in New York on upper brackets, and every time we do that, people predict doom and gloom and tell us that we're going to drive people out of the state, and it never happens. And there's no evidence of it happening. You know, picking up and leaving New York or moving your money out of New York is not an easy thing to do. And by the way, a fair number of those upper income taxpayers are the people who today, at one or another point in their family's life, are likely to have a good chunk of their savings wiped out by long-term care costs. And under the New York Health Act, that would never happen again. And I think as upper income New Yorkers realize that never again will their savings be wiped out by long-term care costs, that will make an awful lot of people feel a lot better about keeping themselves and their money in New York.
Anybody else on that question?
So Rand projected the cost would be $139 billion in new taxes. That's absent long-term care. The state spend for Medicaid on long-term care is $20 billion. Private pay, commercial market is another roughly $30 billion. So that's another $50 billion onto 139. In our judgment, as I mentioned, the assumptions are highly speculative, and you need to obviously get what's driving the underlying cost. So in magnitude, you're looking at tax increases in excess of $200 billion, which would, if you compare that to any other state or the history of New York, or even the New York State budget at $175 billion, it is a comparison that is, you know, beyond imagination in terms of the economic impact on businesses and on individuals.
No, first of
If I
all,
may
first,
for 1 second. So how much do we actually, if you add up what is spent on Medicare, on Medicaid, private insurance, out-of-pocket, premiums, if you add all of that up right now, if you add all of it up right now, how much do we spend? Now, you might not have that number on the top of your head, but the goal here is to actually start thinking differently about how we fund healthcare. The idea that currently it's, if you get the right job, you'll get the right insurance, and if you wait for the 30 days, like I said about that lady earlier, then you'll have access to the health insurance that you didn't have before. And then that lady, for example, there will be some costs incurred, obviously, because she discovered that she had this blood condition, et cetera, et cetera, et cetera. The goal here is to actually shift what would be the costs that we are currently expending. These are things that are currently happening. That's the one thing that, when this discussion happens, it is easy for some of the opposition to very quickly grab onto that number, and everybody gets their hair on fire and screams out of the room. The question that we have to ask ourselves is, how much do we currently spend in the system? How much do we currently spend on healthcare? And if we add all that up, and what we're saying is that we want to switch where the money from that comes from. And if it's more, and one thing that we haven't spoken about is the idea that having everybody in the same risk pool actually lowers costs for everybody. The idea that we might actually have lower mortality or lower, or actually have people that don't currently have access to primary care, or who make decisions about whether they go to primary care or not, on whether they can afford it or not. If we take those things and we add it all up, that is what we're doing here. And yes, it is a fundamentally different way to organize how we deliver care. But ultimately, again, and this is the last sentence of words, But ultimately, what we're saying is that your wealth should not determine your health. And the scary number that we're talking about, the current number is scary. It's just coming from different places.
Let me ask one more and then go to the audience because time is getting a little short.
Okay.
I'm going to try to get everybody in
And I
if
have
I can.
17 minutes, and I gotta go, because I gotta go past the New York
So
Health
this-
Act out of my committee.
Right, so this was smaller, right? There are health economists who say co-pays and deductibles, they're important. We need them to curb healthcare spending. We need them to discourage unnecessary care. All of those go away under the New York Health Act, and for a lot of people, that's one of the most attractive parts. No more premiums, no more co-pays, no more deductibles. That sounds fantastic. There are others who say without those, constraints in place, we're in trouble. What are your thoughts about provider supply and capacity?
There is no evidence that I've ever heard of that deductibles and copays discourage unnecessary care, as opposed to discouraging care. And patients don't go for care that they think is unnecessary. Patients go for care that they think is necessary. And if a deductible or a copay gets in their way, it's getting in the way of care that they think is necessary. And, that doesn't apply to wealthy people. The Hermes company sells a $13,000 lovely shoulder bag. They sell them in 6 different colors. There are households in my district that own a complete collection. Those folks are not deterred from getting health care by a $2,700 deductible. It's ordinary working people who are punished by deductibles and copays and blocked from getting the health care that they and their doctor believe they need.
Okay,
And
I hear you on
it
that.
is
What
it is
about the-
outrageous to
what
me
about
to
the
think
provider
that we have a
supply
system
side?
in which a profit-making insurance company gets to decide whether you need the health care that you and your doctor think you need. But not if you're rich.
So I hear you on that, and we'll take the necessary, unnecessary part out of the question. Just what about provider supply and capacity under a different system? What should we think about that?
Well, again, I think you're talking about benefit design, and benefit design is critically important. We think that, again, the benefit structure should be designed to actually reduce barriers, particularly for people who have chronic illness and for preventive care. But in terms of, providers don't want patients to get the right care at the right time, at the right setting. But for the most common example is sometimes patients will seek care in the emergency room when really they can go someplace else. So it's really about redirecting where patients go, but we want patients to get the care that they need. In terms of, just if I could say a couple quick things around the switch to single payer, there could not possibly be a switch. There would have to be a multi-year transition period. And in going to that, one of the principles that I learned in Vermont was that the higher the income, the higher the mobility. That's why when Governor Shumlin looked at the final economic study, he realized that his tax base would just change their domicile. They could still live in Vermont, but they would be domiciled elsewhere. And I think that, again, that was a concern that was raised in the RAND report. And it's a factor to certainly consider, but the costs of the transition are enormous, and were another factor of pulling the plug. But I think the whole idea around benefit design and having one single benefit design that 19 million people would fall under is probably unlikely. We already have unions in the city that are opting to try to get out, because if there is some copay or the benefit design isn't as good as what they have under their union contract, they won't want to be part of it. And the same happened in Vermont.
Let's go to the audience in the time we have remaining. If you could raise your hand, tell us who you are, and keep your question brief. That would be awesome. Yes.
My name is Fred Hyde. Question, especially for the public leaders. Instead of supplanting existing coverage, what would your reaction be to supplementing it? Give given the fact that you focus at least as much on the incredible patient responsibility, so to speak, as you have on the uninsured. In other words, a single supplement available as opposed to a supplanting.
Well, the problem with that is that the way you pay for eliminating deductibles and the way you pay for paying doctors and hospitals more than insurance companies want to pay them is by extracting the savings from insurance companies and from the waste that doctors and hospitals have to pay for to fight with insurance companies. If you are adding complexity to that system, instead of eliminating complexity from that system, there's no way it can work.
Okay.
The whole point is to get insurance companies and the problems they create out of the system, because unless you get rid of their taking 18 cents on the premium dollar, and unless you get rid of their ability to make life hell for doctors and hospitals and patients, you can't free up the money to pay for healthcare and to put money back into people's pockets.
Thanks for the question. I think there was a woman here in the third row. Did you have your hand up?
My name is Jackie George, and I'm just curious about your perspectives on value-based payment and alternative payment contracts. You mentioned part of the challenge is we need to think differently about how we pay for healthcare. And this is a mechanism that's being piloted, for lack of a better word, across the country and in different parts of New York State to try to drive, to your point, quality and efficiency in the delivery system. And by trying to address some of the root cause of what we spend and address some of the administrative challenges that have developed in the in the provider side of the equation for lots and lots of different reasons. And I'm just surprised no one's made mention of that. And I'm just curious what your
Thanks. VBP,
perspectives are.
innovation, what about that?
I'm a
Well,
fan.
yeah,
We support it.
yeah, so the bill as it's drafted today would go back purely to fee-for-service.
That's what I was surprised at.
No,
And-
that's bunk. The bill says that until you develop alternate systems, you will use the old system. There are, value-based payment may well be a part of it, may well be a part of it from day one. The thing about value-based payment is that any payment system either does good or does enormous damage based on who's in charge and whose interests it is being designed to further. And if insurance companies are running value-based payment to maximize the return to their stockholders, value-based payment will be a very nicely wrapped piece of horrendous stuff that will do enormous damage to patients and doctors and hospitals. If it's run by people who are accountable to the public and not to stockholders, there's a shot it may well be run very well. And that's why the New York Health Act is open to it. It's all a question of who pays the piper, because he who pays the piper calls the tune. And when a for-profit insurance company is designing and implementing the payment system, they do it not to benefit you. The insurance company, as Andrew Cuomo once said, is not your friend, they're not your uncle, they're not your doctor. They're in a business. And as long as they're designing the system to maximize return to their stockholders, that screws me and you and our doctors and our hospitals.
All right, I think I saw a lot of hands in the back, right here and then there. You first.
Kathleen Moore from the Post-Star in Glens Falls. Up in Glens Falls, there is such a demand that they're having difficulty, without getting rid of deductibles and copays, having difficulty getting enough doctors. If you were to get rid of deductibles and copays, which even some of the unionized school union folks say is too high for them to go to the doctor now, will there be enough doctors?
Well, essentially what you're saying is that the current system is keeping people away from getting health care that they need, right? That's pretty outrageous to me. Now, if we have to figure out something to do to recruit, to persuade more doctors that what they really want to do is practice medicine in Gloversville, we should be doing that. But let's at least stop standing in the way of people going to the doctor. And by the way, if doctors in Gloversville could spend all of their time doing what they went to medical school to learn to do, namely take care of people and not fighting with insurance companies, I think they'd be a lot happier to live and work in Gloversville.
There's a gentleman right there.
My name is Richard Wells. I noticed in the bill, it says that it doesn't have any brackets or rates for the taxes that are going to be used to pay for this. How can you expect anyone to support this if we have no idea what it's going to cost us out of our paycheck every year?
Well, we do have an idea what it's going to cost us. We know in the gross numbers what the savings are going to be and how much revenue is going to have to be raised. The exact income brackets and rates will depend on the distribution of income 2 or 3 or whatever years down the road when it's ready to be implemented. And the fact that it will be progressively graduated certainly indicates where those rates are going to be. Today, you know, if I said to you, what's your insurance premium going to be 5 years from now? You don't know. You don't know what your insurance company is going to demand of you. You don't know how high your deductible is going to be several years from now. And, you know, that's part of the problem. And at least under the New York Health Act, that will be determined in a small d democratic fashion that is accountable to all of us. If you're angry at the people who run the New York Health Act, you know where their board of directors meets. They meet in the state capitol. You know how to go and yell at them. I don't know about you, I have no idea where the board of directors of my insurance company meets. And if I knew where they met, they wouldn't let me in the room.
Okay, thanks. So fellas,
Without knowing what the cost is going to be to them personally.
okay, so this guy is tough. He keeps flashing these signs at me saying I have a minute. So I'm taking the final minute. I'm going to ask the last question. I guess it's really for the sponsors. You have said that we should expect to see a new version of the bill in this session. Why don't you give us a preview of what we can expect?
We have, well, it will be reintroduced soon. So one of the things I was going to tell the gentleman is that we have a new version of the bill. And granted, to get back just very briefly to taxation scheme, there is a lot of it that has to be determined during the transition phase, because I agree with B on this one. It can't be a flip of a switch. It has to be a transition, and we do agree on that. And they're much like there's a lot of other bills that we approve every day that give authority to the administration or to a group of people that we create to actually make up the regulations for a particular piece of legislation to actually be implemented. It would be similar to that, and there would be an ongoing discussion about exactly how it's going to be structured. But to answer your question, we will be introducing a bill soon. We don't have an exact time for it yet. There are some technical tweaks that need to be done on it, and there will be an addition. It's already out in the universe. Long-term care would be added to the bill, but you can expect to see a bill certainly this session soon. I don't have more exact time than that. I don't know if Phil wants to.
Yeah, the adding of long-term care, which nowadays people say we should call long-term services and supports, 5 syllables instead of 1. That will be a major new feature to the bill. There are a couple of technical tweaks that we will make. We will be clarifying at the request of the Medical Society that there will be no prior authorization called for in any way more restrictive than what you now have under Medicare Parts A and B.
Thank you. We could go all day long, but we only had an hour, and it has flown by, so please let's all thank the panelists.
I want to thank the panel, too, on behalf of the Empire Center. Thank you very much.